evening, and on behalf of Dr. Guy Mintz and myself, we would like to welcome you to the National Lipid Association's The Lipid Panel. My name is Merle Meyerson, and like Dr. Mintz, we're both cardiologists and lipid specialists. The Lipid Panel was conceived to be a lipid clinic similar to educational conferences held at academic medical institutions. For both those who have these conferences and for those who do not have in-house conferences and colleagues, the Lipid Panel is a great way to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies. Find out the most up-to-date information and come together with those in the lipid and cardiometabolic community. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions. And we will try to cover as many important clinical topics every lipid specialist needs to know. If you have thoughts about topics to be presented, please be sure to let us know. We're preparing for our 25 to 26 season now. The Lipid Panel does offer CME. We are not offering it for this evening's session. We hold our sessions on the last Tuesday of each month, except for December, July, and August. All sessions are taped and available for viewing on the National Lipid Association website. So I'd like to introduce our panelists tonight, and first is Dr. Sotirios Tsimikas, also known as Sam. He is a cardiologist and professor of medicine and the director of vascular medicine at the University of California, San Diego School of Medicine. He obtained his medical degree in internal medicine residency training from University of Massachusetts Medical School and separate fellowships in cardiovascular medicine, atherosclerosis and molecular medicine, and interventional cardiology at University of California, San Diego. He directs a basic and translational research laboratory at UCSD focused on Lp(a) and is the founding director of the vascular medicine program within cardiology. He also founded the UCSD's Lp(a) clinic to diagnose, manage, and follow patients with elevated Lp(a). Our case presenter is Natasha Vartak. She is a preventive cardiology fellow at Northwell Health. She completed internal medicine residency at Lenox Hill Hospital and medical school at Touro College of Osteopathic Medicine. She obtained her Master's of Science in Biochem and Molecular Biology at Johns Hopkins School of Public Health. Her research interests include cardiometabolic health, genetics, and implementation of related programs into clinical care. And our moderator and co-lipid panel chair is Dr. Guy Mintz. Dr. Mintz is director of cardiovascular health and lipidology at the Sandra Atlas Bass Heart Hospital, North Shore University Hospital, Northwell Health, and is director of the lipoprotein apheresis and co-director of Lipid Center. Dr. Mintz is a leader in the National Lipid Association, serves on many committees, the Executive Council, and Board of Directors of the National Lipid Association. He is twice president of the Northeast Lipid Association chapter. He's an associate professor of medicine at Zucker School of Medicine. And with that, I'll turn it over to Dr. Mintz to begin our lipid session this evening, focusing on lipoprotein(a).
Thank you, Merle, for that introduction. And without further ado, I'm going to turn the program over to Dr. Vartak, who'll present our case for this evening.
Yes, thank you, Dr. Mintz. I wanted to start with an audience response question just to get everyone thinking about lipoprotein(a). So which of these patients should have their Lp(a) checked? A 24-year-old female with no significant family history, B, a 50-year-old male with coronary calcifications and hyperlipidemia on statins, C, a 38-year-old male with 3-vessel coronary disease whose father had a heart attack at 42, or D, all of the above. So please answer as you see fit.
All right, Sam, you want to comment on the audience response before we embark on the case?
Yes, thank you, Guy. There's an evolution of thinking on this, and many of the guidelines now, including the NLA and the European guidelines and the Canadian guidelines, recommend every adult have an LPA level checked at least once. So I think the correct answer based on those emerging data is now to have it be D. There's been a little controversy in the past about maybe just choosing the highest risk patients, but I think the field is moving towards pretty much everybody should get an LPA level checked at least once.
Okay, I agree with that. All right, Natasha, why don't you present this interesting case for us?
Yes. So to start with our case, it's a 66-year-old male with a past medical history of type 2 diabetes, hyperlipidemia, sleep apnea, coming into his cardiologist with chest pain and shortness of breath. He says his highest ever LDL was 220, and his triglycerides are normal. His A1C is well controlled. He has no early family history of coronary disease. And his current medications include aspirin, rosuvastatin 40, Zetia, and fish oil. Because of his symptoms, he's sent for a nuclear stress test. It comes back abnormal and consistent with ischemia. He then goes for cardiac catheterization, where he gets a stent to his LAD. And after this, he's also noted to have a residual 50% lesion in the proximal circumflex. He then has prasugrel added to his aspirin. He follows up later, and he basically is complaining to his cardiologist that he's feeling unwell and he has a bubbling sensation in his neck. He goes for carotid Dopplers, and he's found to have this severe plaque in his right internal carotid, for which he gets a carotid endarterectomy. And at this time, his medications are rosuvastatin 40, Vascepa 2 grams twice a day, Zetia, aspirin, prasugrel, and empagliflozin metformin combo.
And
Fast
Natasha,
forward,
Natasha, the LDL of 220 is significant for?
familial hypercholesterolemia.
All right, just want to make that point. Okay, continue.
So fast forward a few years, now it's September 2022. He comes to the ER with severe epigastric pain that's radiating to his neck and left arm, and it started after he had a meal. His vitals are largely normal, and at this time, his medications are the same. He has troponins checked that are negative, but his EKG is concerning for ischemia. And prior to this event, he had had an LDL checked, and it was 57. He goes for cardiac catheterization again, and he's noted to have a 95% calcified proximal lesion in his LAD, which is not in the stent. I just want to make that clear. And this new lesion is stented. The other arteries are reported as normal. So I wanted to ask the audience, if you're seeing this patient who's having progressive coronary disease and carotid artery disease, despite having a well-controlled LDL-C at 57. So what do you think we should consider for him next? Should we just continue his current regimen of medications? Should we B, add a PCSK9 inhibitor, C, check his ApoB level, or D, switch his statin from rosuvastatin 40 to atorvastatin 80?
So while the audience is putting in their answers, you have a patient with an LDL target of less than 70 milligrams per deciliter with optional target of less than 55 milligrams per deciliter. So he's close. Let's see what the audience thinks. Okay, Sam, you have any comments on the audience response here?
Well, the audience is saying add PCSK9 inhibitor, and obviously the idea for that is to lower the LDL even more. Check an ApoB level, and then the other two choices were not really popular. So continue current regimen. I think people realize here this patient is having progressive events, so something else needs to be done, and including maybe diagnostic avenues to maybe understand his lipid parameters better. Switching Rasuva 40 to 80 doesn't really get you anything. That's basically a kind of an equivocal type of response. So it's the other two that are important here, and they're not necessarily, one is a diagnostic, one is a therapeutic, and we could discuss this a little bit more in terms of what might be going on in this patient's lipid profile that we might want to further interrogate. So, initial idea to lower the LDL is good, but I think we need to kind of think through a little bit more about what the patient is undergoing in terms of the pathophysiology.
And that kind of leads me to the next question is this patient's LDL-C measurement truly accurate? And Dr. Tsimikas, feel free to comment on what you think.
So the audience is going to vote here?
Yeah, they're going to vote.
Let's wait for that. Yeah.
Yep.
So maybe we can just, while they're voting, just talk some generalities here. So usually the LDL cholesterol that is obtained from a lab is not measured directly. It's estimated either using the Friedwald formula or the Hopkins formula, which is a little bit better for the patients that have higher triglycerides, maybe like him. So that's one thing to remember. It can also be directly measured. It's not usually done. Both of those, though, have a specific issue that we're going to discuss in a little bit. And so, yeah, the audience response is, yes, it's accurate. 9%, 48% no, it's not accurate, and 43% unsure. I think those are fair responses. And so, I think we need to kind of look into this more to understand if it's accurate or not. So you want me to discuss that, or you want to go to your next slide and then we can kind of do that in more detail?
Sure. Let's see the next one.
So continuing on with the case, and now it's November 23, he's coming back to his cardiologist, and his LDL is now 45. In the interim, he had bempedoic acid added. For reasons unclear, he had insurance issues with adding PCSK9, and so this is the alternative that was pursued. After this, fast forward to July 2024, he's again back in the emergency room with chest tightness and epigastric pain. His troponins are negative, EKG was not ischemic, but his cardiac cath shows a severe calcified LAD disease and a 90% osteal circumflex disease. And his LDL-C is 44. He undergoes CABG ×2, and after this event, he finally gets the PCSK9 approved. Fast forward to a few months later. Now this is his new lipid panel, total cholesterol at 104, HDL is 42, his LDL is 24 now, and triglycerides have always been well controlled, as has his A1C. And what's important to note is this patient is still having progressive cardiac CAD despite having this very low LDL of less than 30. And now his medications are rosuvastatin 40, ezetimibe, he's still on the Vascepa, he's on Repatha now, as well as his dual antiplatelet and metformin. And I just wanted to go to the next slide to kind of give you a visual idea of where his LDL has been throughout all these events. So back from 2019, when he first came to the office, all the way to now, and you can see his LDL has remained very low as we've progressed with the time and had various medications added, but he's continuing to have progressive coronary disease. I'll take a pause for another audience response question. What additional testing would you consider at this time? Would you A, check a high sensitivity C-reactive protein, B, check his ApoB, C, check his lipoprotein A, or D, check his LDL particle number?
Yeah, while the audience is answering this question, I think what you're seeing here is a patient who's had two major events of progression of atherosclerosis with an LDL under 70. And despite pretty much getting the full court press on all the meds that can be given for lowering his LDL. And so that's raises some eyebrows about what's going on in this patient. Okay, so the audience question. So 87% choose check an LPA. That's really great choice. The other ones are interesting, but they're probably not going to get you, the kind of information you need to understand why this patient keeps having events on an LDL that's very well controlled. So I think I fully agree with that. I think that's the best approach in this case.
Okay, you go to the next slide, Natasha. It's always good to know the title of the lecture to answer some of the questions. Okay.
We finally get some answers that we've been thinking about so far. So his lipoprotein A is 211.9 nanomoles per liter. And then I put down his ApoB, hsCRP, and LDL as well, just so we can get a full idea of his risk.
So probably nobody's surprised at this point that his LPA is elevated, and this is a very classical presentation. And it was a lot more common in the past where somebody would just keep coming in and getting procedure after procedure. And after the third, fourth, fifth, somebody would go, oh, I better check something else. You know, it's not the LDL. And so this is not an unusual situation. If we go back to your first question, you know, who should get an LPA level checked? You know, with the way the guidelines are changing, this patient would have been diagnosed 5 years ago with this issue. Now, the question is what to do. We can get that at the end of the talk, but you know, this could have been less of a dilemma in terms of a diagnostic dilemma, in which case, what's driving his disease. Obviously, the LDL is contributing because it was 220 when, you know, when you first checked it, and so that's in the familial hypercholesterolemia range. But about 40 to 50% of people with familial hypercholesterolemia have elevated LPA. And this is not as well appreciated, but it's published and in several studies. And the mechanism that may be that when you have familial hypercholesterolemia, one of your LDL receptors out of the two is malfunctioning. And there is evidence suggesting LPA, it gets cleared partially through the LDL receptor. And so two things happen when you have FH in terms of the LPA story. You have lots of LDL. So the LDL and the LPA now fighting for that receptor binding. And if you have a lot of LDL, like in this patient, if you convert this to millimoles or nanomoles of ApoB versus, say, nanomoles of LPAs, probably ApoB nanomoles when he first started out at 200, that's about 4,000 nanomoles of ApoB. And you have about 200 nanomoles of LPA. So you have about 20-fold more ApoB than LPA. So they're fighting for that one receptor. And what ends up happening is that the LPA gets displaced off and it goes up. So patients with FH for the equivalent genetics will have much higher LPA. So whenever you see a patient with high LDL, you should think they probably have a good chance of also having some high LPA because of this mechanistic of the competition of the two particles for only one receptor. So that's a nice clue for you to kind of find these patients early on when you notice their LDL is elevated.
So Sam, here's one from the audience. Since the LPA carries cholesterol, how can the LDL-C be so low when the LPA is so high?
All right, that's perfect.
Clarify that.
I think we have a slide of that. I wonder if we should go to that. That would be a good topic to discuss. Is it on the next, is it on the next slide maybe, or is it one of the backups? The cartoon that shows the LP cholesterol content. If you
Do you want me to
yes,
just go forward?
why don't you go forward one? Let's see, is that okay, it may be one of the other slides.
Keep
So
going on
let
the
me,
Sam slides.
yeah, if you, sorry, we're going to go back and forth here a little bit. Go forward and one more. And one more. One more. Sorry, I thought it was in here, but
It
one
may
more.
be the last slide.
Yeah,
Sure.
we'll discuss it now because I think it's important to
The last slide, I think the hidden slide.
Oh, got it.
okay. I know this is a cartoon, but let's just go over this for a second. This is a great question. So back to the LDL measurement, when you do any kind of LDL measurement, whether it's calculated, whether it's a direct LDL, and that uses kind of reagents to kind of strip away the VLDL, and so, or remove it from the measurement, or even if you do ultracentrifugation that uses density to separate the particles, LPA and LDL particles overlap in size and density. And so you can almost never, at the clinical level of this, even at the research level of ultracentrifugation, you have to do some special ways to isolate LPA. And we do that in my lab, but you can't really do this in any kind of like clinical setting. And so whenever you see an LDL measurement, you should assume that it has the LPA cholesterol content in it. And the LPA cholesterol content will be a proportion of how much of the LPA is carrying. So just to put that in numbers, let's say that 30% of the mass of LPA is cholesterol. And so let's say you have an LPA of 100 milligrams per deciliter. Just use that unit for now. If 30% of that mass is cholesterol, you're going to have 30 milligrams per deciliter of cholesterol on your LPA. So if the lab is telling you your LDL is 70 and you have an LPA of 100 milligrams per deciliter and 30% of that is cholesterol, your true LDL is going to be 40. Your LPA cholesterol is going to be 30. The lab is going to tell you it's 70. So your instinct is, I need to get the LDL lower at 70. But in this kind of patient, that's the highest LPA. No, not really. The LDL is already 40 and the LPA cholesterol is 30. So what this cartoon basically shows you is that we devised a way to measure LPA cholesterol directly rather than using the 30% estimate, which is inaccurate. It's not individualized. And so we can immunoprecipitate out the LPA, and then we clean it up. We remove everything from that test tube, and then we just measure the cholesterol directly on it. We've published several papers on this, and we're now trying to get this into clinical labs. So what I'd like to see in the future for this kind of patient is the lipid panel being redefined. And the way it should be redefined is total cholesterol equals LDL cholesterol plus LPA cholesterol plus HDL cholesterol plus VLDL cholesterol. And the VLDL, you can take triglyceride divided by 5 if it's under 400. And so if you go back to that slide where the LDL was 24, what it's basically telling us is that this patient probably has very, very little amount of LDL left. So if you have a 219 nanomoles per liter, let's say that's about 80 or 90 milligrams per deciliter. So if his LDL is 24 and that 80 or 90 is, let's say 20%, it ends up to being about 24 milligrams per deciliter. So if you could actually measure his LDL directly in a way that's not in any of these 3 ways I mentioned earlier, you might find that the LDL is essentially 0, and all this cholesterol that's coming out as 24 is probably LPA cholesterol. And you won't know this unless this technique that I described becomes clinically available. So the bottom line is you probably weren't getting a lot of bang for your buck by keep giving LDL lowering agents because the LDL is already very low. Those agents don't necessarily affect LPA cholesterol very well. In fact, statins tend to raise LPA and LPA cholesterol. PCSK9 inhibitors lower a little bit. Bempedoic acid is neutral on LPA. And so if you had a way to kind of understand what the lipid panel really looks like, when you first diagnose this patient with high LPA, you might have been inclined to, well, this is different doctors taking care of this patient, but I'm just speaking in general terms. You might have been like, oh my God, maybe it's the LPA is the problem all along, and I should focus on that because the LDL is lower than I think. And that concept is going to come out a lot in these patients with high LPA. So I can't tell you what the real LDL is, but if it's 24 and that LPA is that high, it's probably almost non-existent in terms of LDL.
Okay, go ahead, Natasha.
I just wanted to really highlight the lifetime risk for major cardiovascular events as your LPA level increases. And we're seeing all the top 3 lines are at these LPAs of greater than 50 megs per deciliter. And you're really seeing people are having exponentially higher lifetime risk of ASCVD. And this brings me to the 2024 update to the FNLA statement on lipoprotein A. And we've kind of been talking about this, but LPA should be measured at least once in every adult for cardiovascular risk assessment. The use of an adjustment factor to estimate calculated Lp(a) for correction of calculated LDL is not recommended. And we're going to talk about this a little bit more in the later slides, but although statins may increase lipoprotein A levels, concerns about Lp(a) elevation should not be a reason to discourage or discontinue statins. And LPA really exists on a spectrum. And so the high risk patients are these patients with greater than 50 mg per deciliter of Lp(a). That's equivalent, or the same category is greater than 125 nanomoles per liter. And your low risk patients have less than 75 nanomoles per liter or less than 30 mg per deciliter. And then everyone else is kind of in this intermediate risk. And just another slide from the European Heart Journal to show you that your risk of clinical outcomes increases as your Lp(a) increases. And that includes aortic stenosis, ischemic stroke, myocardial infarction, and heart failure. So just another reason that we should be checking this for all of our patients.
Well, Natasha, I think one thing that we should talk about right now, since you're right at it, is this risk of LDL versus LPA. I wonder if you might go to the slide that had the balance of the particles. I think that one is worth going over in some detail here. Okay, perfect. So let's think about what the risk of each one is. So this is on the study on the left that was just published. It was a great study. They asked the question, if you had genetically determined elevated LPA and you had genetically determined elevation of ApoB, and you ask the question, since we know that ApoB, there's one ApoB on an LDL and there's one ApoB on an LPA. And so if you look at variants in the top left that raise ApoB by raising LPA, you can put them in one bucket. And then on the bottom, that's called the LPA cluster. On the bottom is the LDL cluster. If you now have variants that raise ApoB, but only raise LDL, then you can put them in a second bucket. And then you can ask the question, okay, I have the same amount of ApoB in each one of these particles, these genetic clusters. And now I'm going to ask the question, what is the risk of CVD, assuming the equal molar amounts of ApoB? Okay, and what you see on the graph that says Mendelian randomization is the genetic effect of ApoB that's either on LDL or LPA. And you have two curves. One is on LDL on the bottom and one is LPA on the top. And so what you see is the curve for the ApoB and LDL is flatter. I mean, they're both associated with high risk on the y-axis, but the ApoB and LPA is associated with higher risk. So what this does is it normalizes the amount of particles and says per particle, what is higher risk? And the conclusion from this study was if a patient has the exact number of LDL and LPA particles, the risk of LPA is 6-fold higher. And what it's saying is an individual particle of LPA is 6 times more atherogenic than LDL. And we'll come back to that other cartoon that you just had on the potential mechanisms. Now, if you look on the right, that's not the whole story. That's only half the story. So if a patient had one particle of each, what would happen is the scale would tilt to the left on the right side because the LPA is more atherogenic. So for the same amount of LPA ApoB and LDL ApoB, what you're seeing here is this pro-inflammatory oxidase phospholipids on LPA. It has a pro-inflammatory proteome, meaning other proteins that stick to it are pro-inflammatory, like complement factors. It's smaller and it's denser, and it has this antifibrinolytic effect. When you look at the LDL, it doesn't have a lot of those issues. However, in reality, most people have a lot more LDL particles than LPA. Like in this case, for example, when we talked about the ApoB, when the patient wasn't treated, you can assume 100 milligrams per deciliter of ApoB is about 1,950 nanomoles per liter of ApoB. So when he started out, let's round out to 2,000 just for the sake of argument. When he started out, he had 4,000 nanomoles of ApoB, and then he had 200 nanomoles of LPA. Now, when he's coming in, his ApoB was 60, let's say, just 66, I think it was. So now he has about 1,200 nanomoles of ApoB, and he has 200 nanomoles of LPA. So he still has 6-fold more ApoB particles that you see on the right. So the scale now tilts to the right. He's got 6-fold more ApoB particles than he does LDL ApoB than he does LPA. So, but LPA is 6-fold more atherogenic. So at this point, what's happening is it's a particle probability game, and also it's the atherogenicity of each particle. So you almost have to, if you were going to do like a math equation, you would take the number of particles and multiply it by something like an atherogenicity index to figure out what's going on. So the bottom line is they're both atherogenic, they're both bad. The lower you get the LDL and you can't treat the LPA, then the LPA now becomes very atherogenic because it has all this extra risk with it. And so it kind of teases out, individual versus all the particles together in terms of the risk. And you put that together and you have a patient like this where you kind of got rid of a lot of his LDL mediated risk, but you're now left with a lot of the LPA risk remaining.
Sam, there's a question from the audience, I guess a little more explanation. You mentioned LPA elevation, which is common in patients with FH, possibly related to LDL clearance of the LPA. Is this the case why we don't see improvement in LPA when we increase LDL receptors with various medications, including statins?
Yeah, that's a great point. I wonder if you might go to that statin graph. That's worth discussing the risk, what happens to LPA when you give a statin, and then what's the mechanism behind some of that? That's a great question. And it was this one. Okay, so, I think a general concept is many of the things that lower LDL tend to cause the LPA to go in slightly the opposite direction. That includes dietary factors. That being said, I can give you a little anecdote, and it's not on the slide, but in 1989, a paper was published with lovastatin. And the title, and this was a circulation, the title said, lovastatin lowers LDL without increasing, without reducing LPA. And the title was inaccurate because what it showed is that the LPA actually went up. And I think that was a little bit of an editorial thing from the authors, not to say that statins raise LPA at the very beginning when they were getting generated. And the journal probably made a mistake to allow that title. And so this issue keeps recurring as we've seen recently in this ketogenic diet, but that's another issue. So we decided to look at this formally. And what you see on the left is we have 6 studies where patients were never on a statin, got placed on a statin, and with placebo groups. And what you're seeing is on the red is a statin effect, and the green here is the placebo effect. There's a slight increase in LP in the placebo effect because a couple of studies were acute coronary syndromes. So there's a little bit of an acute phase response. But the bottom line is if you do subtract the green from the red here, what you get is about a 20% increase in LPA when you give a statin. Now, it hasn't been really linked to a worse outcome, but what it's telling us is that the mechanism is different. So we know statins upregulate LDL receptors, and you would think if that were to happen, that you would have a lowering of LPA, but it doesn't happen. It actually, if anything, it goes up a little bit. Now, on average, if you look at the particles, you have a massive lowering of ApoB and LDL with statins, and you have a slight increase in LPA. So I think on average, the patient is better off. So the teaching is don't stop the statin if you see a rise in LPA, because you're going to get a benefit from the LDL side. But the other part is you need something specific to treat the LPA. Mechanistically, we've actually, in this study that you see here on the bottom left, we actually have some cell culture studies in here. And what we noticed is statins increase PCSK9 protein levels in cell culture. And then we linked the increase in the PCSK9 protein to a higher production of ApoA. So what's probably happening is, despite the upregulation of the LDL receptors, they're not very avid for binding LPA. And the increase in the PCSK9 protein and the production of ApoA in the liver probably overcomes any kind of clearance effect that you might have from the statin. And the net effect is you have this kind of modest increase in LPA when you give a statin. When you give a PCSK9 inhibitor, you do get a reduction. Here, you get increase in LDL receptors, but you also suppress the production of ApoA, or at least the circulating ApoA, circulating PCSK9 that could interfere. A lot of the other agents are kind of neutral. Niacin lowers LPA. The mechanism there appears to be reducing production of ApoA. It doesn't have a receptor-mediated effect. And of course, the ASOs and the siRNAs inhibit the production in the cell. So it's a little bit complicated. There's a lot of stuff, a lot of moving parts. All that being said, what the graph on the right shows is, then this was a meta-analysis we did in a very large number of patients, as you see here, almost 30,000 in 6 of the statin trials, that when patients were on a statin, their LPA-mediated risk did not go away. In fact, it wasn't even modified at all. And a lot of papers are showing that. And so what you see here is the LPA level in different categories. And even though patients are on statins, they still have this increased risk once the LPA level goes above, let's say, 15 to 30. And so what it's telling us is statins are great for LDL-mediated risk, but they don't seem to affect LPA-mediated risk. And of course, the implication of that is we need something more specific to affect LPA-mediated risk.
I'm just going to go back to the cartoon image.
Yeah, maybe
Okay.
Sam, you can tell us some of the mechanisms for
Sure, perfect.
how LPA can cause such progressive disease.
Yeah, so here's your LPA particle. The lipid component has one ApoB, and it looks like LDL-like, although we know it's heterogeneity in the size. ApoA is covalently bound to Kringle by Kringle 4-9 to ApoB, so it circulates as a lipoprotein. But notice ApoA is actually not a lipoprotein, right? Notice it has no lipid on it, so it's sitting in the aqueous phase. And so it's because it's derived from plasminogen, and plasminogen doesn't accumulate lipids. So technically, ApoA is not a lipoprotein. It's basically a plasminogen derivative. And somehow through evolution, these things got together, and the blue there where it says P, that's a protease-like domain. It's inactive, unlike plasminogen. So when you give TPA, like for a stroke, what you're doing is you're activating the protease domain of plasminogen, creating plasmin, and that degrades fibrinogen. That can't happen with ApoA. So one of the hypotheses is that, well, if you now are forming a clot and you want to now convert your plasminogen to plasmin, that's fine. You can start degrading it. But if you have very high LPA, you're going to have competitive inhibition of that plasmin effect because the LPA is going to get in the way of it's going to bind to the same part of the clot. So one mechanism is that LPA is technically antifibrinolytic, not necessarily prothrombotic. In other words, it says prothrombotic here because that's ultimately what happens, but the mechanism is LPA doesn't cause clots to form like you might see with like factor V Leiden from thrombin deficient, access, etc. You don't form clots. What happens is a clot is forming, and then it makes it enlarge faster and then become occlusive. So that's one of the triad here. The second part, I sort of debunked a little bit because I'm telling you that the LDL component doesn't seem to be as much of a strong impetus because there's not as much LDL on LPA as you just have with LDL in general because the number of particles is much lower. The third part was a lot of work from our laboratory is that there are two areas here that you see OXPL, oxidized phospholipids. One is in the lipid phase of LPA that can come on and off. And the second one is there's a covalently bound OXPL, 1 or 2 moles, on Kringle 410. And so the oxidized phospholipids are highly inflammatory. They interact with scavenger receptors and other receptors. They make monocytes and macrophages angry. It's kind of a simple way to put it. And they start releasing all of these cytokines that you see here. And then the cytokines then start recruiting a lot of inflammatory cells. And then you get this sort of degradation of the matrix of the endothelium and the collagen, and you get a thrombosis. And then its antifibrinolytic effect makes that process go even further. So I would say the three main mechanisms that we understand now, and they have probably varying amounts of contribution to clinical risk, is the proatherogenic effect, the pro-inflammatory effect, and the antifibrinolytic effect. And in a way, you can think of this as a diabolical molecule. If you were going to design something that's really bad for you, you cause it to make you get a blood clot, to make you make an atheroma, and to cause inflammation. And that's what it does. All those three things all kind of wrapped up in these particles.
Okay, great. All right, you can mention this, Sam, and then we'll.
Yeah. So one of the things that we realized is we can actually measure the oxidized phospholipids on ApoB particles. We've now done a lot of studies with this, and in some studies, the OXPL per ApoB, it summates all the LPA risk, but also any OXPL that's on other ApoB particles. So in many studies, its predictive value is similar to LPA, but in other studies, if you put them in the same model, the OXPL is a improved predictor. We just had a recent paper on that on aortic stenosis. So we think OXPL is basically a two-hit kind of measurement. One, it summates the genetics of LPA. And two, if you have oxidative stress independently of that, for whatever reason, these OXPLs go in ApoB particles, especially on LPA, and now you have a double hit. You have oxidative stress, you have the genetics of LPA. So if your OXPL is high, that suggests that you have a double hit on top of LPA, and those patients are even higher risk. This can be measured now clinically through Boston Heart Diagnostics, but we're still doing a lot of research studies. And it'll be used in a lot of the LPA lowering trials to understand whether this variable picks up the highest risk patients. They may either be high risk or respond better to the therapy. So there'll be a lot more stuff coming out on that as we go forward.
So I wanted to ask, the audience again, now that we know this patient has elevated lipoprotein A and we know that he is having progressive coronary disease, what would you recommend next for him? Would you A, start semaglutide, B, refer for lipoprotein apheresis, C, tell him to really follow intense lifestyle modifications, or D, continue his current medications and add cholestyramine?
Okay. Good. I think the consensus is to move for lipoprotein apheresis. And Natasha, go to our next slide for the indications for lipoprotein apheresis for LPA.
Yes, so this is the update from the Food and Drug Administration that is just hot off the press. So the indications for lipoprotein apheresis are for patients with homozygous familial hypercholesterolemia who have an LDL of greater than 500, patients with heterozygous FH with LDL greater than 300, and patients with heterozygous FH with LDL greater than 70 who also have documented coronary disease or documented PAD. And the last indication, which is what is relevant to our case, is patients with clinically diagnosed heterozygous FH with a Lp(a) of greater than 60 mg per deciliter or greater than 130 nanomoles per liter, and either documented coronary disease or documented PAD.
So what's new about this last indication is they took out the LDL greater than 100. So they dropped LDL. So basically it's clinical FH, CAD, PAD, and elevated lipoprotein A. So continue with the next slide.
So our patient goes for apheresis and he's getting bi-weekly sessions. So just to orient you, his baseline was 211.9. After that, you'll remember he had the addition of a PCSK9 inhibitor, which lowered his Lp(a) a little bit to 179.7. And then on the graph, you can see his subsequent apheresis sessions. The blue line is the pre-apheresis and the red line is post-apheresis. And so you're seeing after every apheresis session, his Lp(a) is kind of creeping back up.
Okay.
Yeah, so this is, okay, you have this.
Yes, I wanted to ask
Okay.
you, Dr. Tsimikas, what do you think of his Lp(a) going back up like
Yeah.
that?
So first, apheresis is perfect for this patient, right? You're watching him every year come in with another procedure, and it's just so frustrating for both the patient and the physician taking care of him to deal with this. And so apheresis is a great approach. The issue with apheresis, or not so much with apheresis, but the LPA pathophysiology, is the production of LPA determines the plasma level. These clearance mechanisms, obviously, they has to get cleared somehow. But if you kind of do kinetic studies, the how much your liver makes per minute is basically what determines what's in the plasma, and it makes it pretty quickly, particularly in these patients that have high LPA. And so what's been shown in kinetic studies is it takes about 1 week for the level to come back to baseline. And so we typically do apheresis every 2 weeks, but often you need to do it every week and to really stay on top of it. What will happen to LPA is, if you look on the left there, and this is a cartoon, you start out with very high levels and you do pre and post apheresis values, and then you eventually get some equilibrium, which is almost like this patient, honestly. And then it kind of stays. So it kind of stays like that, with each pre and post session. The important thing about apheresis that you see on the right, and there's never been a randomized trial to look at patients that are apheresis eligible, and you randomize them to apheresis versus sham apheresis. That hasn't been done. What's been done is pre and post studies or observational studies. And this is one here from Germany. Germany got approved, apheresis approved in 2007. Dr. Steinhagen-Thiessen was a champion of that, and it was reimbursed. And so they were doing about 1,000 patients a year. And then they were using apheresis for FH and homozygous FH, but then PCSK9 inhibitors came around. Their business went down in FH, but now they're doing about 2,000 patients a year or more, maybe 2,500 patients with a high LPA, which is pretty amazing. In the US, I think there's only about 500 or 600 people getting apheresis, and we're about 4 times larger. But the point of this is that if you look at year -2 and year -1, where you see the 51 and the 91, these are a number of events that happened before the patient went on apheresis. This is kind of like our patient. And then you have a 5-year follow-up, and you see a marked decline in the number of events, about 80–90% reduction once the patients got on apheresis. So apheresis is very effective. It stabilizes your plaques. The angina gets better. The patients do really well. They still have some events, but most of them do quite well. The mechanism obviously here is, in this study, the LDL was already well controlled. It was like around 70, but the LPA was the only thing that was high. So you can argue the only lipid disorder they had left was high LPA. However, apheresis has other benefits. Viscosity, maybe removes or reduces inflammatory markers. I don't know if it's equivalent to lowering LPA, but nonetheless, it works quite well. There is a study ongoing right now with pelacarsen versus apheresis that just completed, and that will get published or at least presented later this year, I think. So stay tuned for that. We'll have some comparative data of an ASO versus apheresis, and we'll see how that works. And if you go back, the slide you just quickly passed, I want to just show the crew. This is unpublished data. There was a one with here. This is a study we did with Patrick Moriarty, and we measured the LP and the OXPL. This is when the patient first got on apheresis. Sometimes you get them when they've had 100 sessions. And what you see is red is LP and blue is OXPL. You see pre and post, you have this staggering effect, and then it kind of slows down a little bit. This is not published, but I just thought I'd show you that to kind of see what happens when you get on apheresis. It's quite effective in lowering both the LP and the oxidized phospholipids.
Okay, so I want to get to the last 2 slides, which are future treatments. And then what we're going to do, Sam, we're going to do a lightning round, because I can tell you there are a lot of questions. So
we'll do short answers.
Yeah, so it's just highlight the future here on the last 2 slides.
Yeah, this is the big picture. LP Horizon is pelacarsen, started 2019. There was a bit of a year delay in COVID. You see 8,300 patients. Entry criteria is about 70 or higher of milligram per deciliter, or about 175 nanomoles per liter. This study has hard endpoints to get into it: MI, stroke, or revascularized PAD. So you have to have a real event, not like a revascularization. And that was done because this is the first trial, and we want to get the sickest patients to be able to prove the hypothesis. It's a event-driven trial. So, and this is the methodology of this study is now published. And so that's available for you to review. But the study was supposed to complete next month, but the number of events isn't quite there yet. So it's probably going to go for another 6 months or so. The primary endpoint is interesting, and this was approved by the regulators. It's going to be a co-primary endpoint. So it's time to CV death, non-fatal MI, stroke, and urgent revascularization in 2 groups, either LPA over 70, which is everybody, or a subgroup of patients, LPA over 90. Initially, we thought that would be maybe the median value, but the median LPA level is actually much higher than this. So 78% of people are going to be over 90. But the bottom line is, if either one of those hits, in terms of statistical significance, it will be considered a positive trial. Ocean A is about 3 years behind. It's olpasiran. That number is actually a little bit higher than 7,000, because this slide was made before that was updated. The LPA level is a little higher, about 80 or 200 nanomoles per liter. The criteria, history of MI, but also PCI in the recent past, or in one additional risk factor. It's going to have a CHD endpoint. Notice there's no stroke in the endpoint. And I think that was done because the organizers of that trial felt LP and stroke may not be as a strong association. So they took that out to make the trial to be more likely to be positive. Of course, it's going to have less events, so it'll be interesting to see how that pans out. The claim LPA is lepidisiran, that's much larger, has very similar criteria to pelacarsen, except that the patient population here allows FH or very high risk for first CVD event. So it's a combination of secondary prevention and high risk primary prevention. And so that's going to read out, if it goes the way it's supposed to, March 2029. Bottom line is the next 4 or 5 years, we're going to have 3 big trials, total of about 30,000 patients. And we'll have the answer of the LPA hypothesis when the 3 of them are finished. Okay, muvalaplin is an oral piece, LPA lowering agent. There's actually another one that AZ has and one that Merck has. So there's actually 3 oral pieces. They all work the same way. They disrupt the assembly of the ApoA binding to the ApoB to make an LPA particle. I personally don't like this approach because we tried this with mipomersen back in the late 2000s. And what we notice is it doesn't actually remove the ApoA, it just prevents it from sticking together. So the ApoA has to clear spontaneously. And we had noticed that the ApoA was coming out of the liver free and it had its OXPL on it. So we were concerned that it may be going into the vessel wall. So I think the companies that are doing these studies have to be careful to understand how the ApoA is cleared when you disrupt the assembly. And that's going to be a critical piece of information. If it's getting chopped up and going to the kidney, fine. But if it's ending up in the vessel wall, then these agents may not be as efficacious as if you just inhibit it in the liver. So that's kind of the issue with those drugs as we go forward. And we'll see the safety as we go forward also when they do larger trials.
Okay, it's time for the lightning round. So Sam, like I saw a patient today, a 39-year-old woman with lipoprotein A of 360 nanomoles liter. No other risk factors other than dad had an MI at 58. So would you recommend aspirin in these patients with elevated LPA? And, what would you do with the young people with elevated LPA since we're recommending testing from 18 on?
Right. That's going to be a big burden for us to figure this out. We're doing a lot of work on this, on aspirin, and you may have noticed we published 4 or 5 papers recently. They're all kind of methodologically, except for the Esprit trial, none of them, the ones that had LPA values were not really randomized to aspirin. The Esprit was. We have an NIH grant now to measure LPA in Esprit and Ascend. And there we have randomized use of aspirin. The bottom line, I think, is if the patient has a family history, I'm more likely to treat if the bleeding risk is low, or if they have evidence of atherosclerosis. So if you had a coronary calcium scan and the patient had already had calcium at age 39, that would tilt me over more to the art of medicine pending, a real trial with aspirin to more likely use it. If there was a bleeding issue, aspirin is not risk-free, you got intracranial hemorrhage. So it's a case by case. I would say if the patient has no coronary calcium, young women, no other risk factors, you might just wait and not go in the aspirin right now. But if there was, something in her own personal issue with she already has atherosclerosis, then you might be a little more aggressive with the aspirin.
Okay. Any benefit to repeating LPA at any point, even after, let's say,
Yeah, that's a great question. Well,
second part was menopause too.
Yeah, 2 great questions. So if somebody has low level, I don't think you need to check it often, or again, a second time. Like, let's say it's in the normal range, under 30 milligrams per deciliter, under 75. But we have noticed that there's a natural variability in the LPA levels that can change 25% plus minus. So if you have a high LPA patient, and every time you check it, you're not going to get an identical number. The variability is about as much as you get with LDL. Triglycerides are much more variable, but ApoB is less variable. And so you might want to check it if you give a statin, if you give a PCSK9 inhibitor, you should check it. And if something happens, in their healthcare. Menopause is associated with about 20% increase in LPA. And the reason for that is estrogen suppresses production of ApoA through the LPA promoter. When you go through menopause, you lose that suppression, and now the LPA level comes back up. So certainly check it in women as they're going through menopause. And in some cases, they have dramatic increases, which is interesting. And we'll have to figure out what to do with that, but that will change in that scenario.
Okay, does it matter if you measure LPA in a fasting state or a postprandial state.
Yeah, generally, no, it's not influenced as much with diet. Triglycerides are, and that's the reason why we do the fasting, because if you have high triglycerides in the morning and you're not fasting, it also affects how LDL gets calculated. So when you don't fast, both the triglycerides can go up, but the LDL calculation is wrong. And that's the reason for that. For LPA, you tend to have a more, there's some variability, but not as much. And so if you have a patient that you want to check and they're not fasting, it's 3 o'clock in the afternoon, send them to the lab to get your LPA. But if you want to do the triglycerides and LDL, you should do that fasting, I think.
Okay, great. And a short answer to question regarding total plaque volume and LPA to see if total risk is higher as the plaque volume increases.
Yeah, there's been a few studies recently with CT angiography, and it looks like the main determinant of what you see on the CT is actually, regarding LPA relationship, is low attenuation plaque, more so than plaque volume, which kind of makes sense because the athero part of LPA is not as big, right? Because you don't have as many particles, but it's that kind of plaque vulnerability that maybe is induced by the oxidized phospholipids. And so if you have the opportunity to look at the difference between plaque volume and plaque, low attenuation plaque, it's a low attenuation plaque I would pay attention to more than the plaque volume.
Okay, great. And just to reiterate, elevated LPA is also associated with aortic stenosis due to inflammation. Sam, is there a target LDL or ApoB that you would shoot for with a high LPA?
Yeah, I would say, as low as reasonably possible for the ApoB and the LDL. Keep in mind that the LDLs are lower than you might think they are. But, if you have a high LPA patient, they're already in a higher risk category than if you had the same patient with the same LDL below LPA. And so, in general, I'm fairly aggressive. I like to keep everybody under 70. If I have multiple events, I think, keeping the LDL even under 50 is fine. Ultimately, though, the answer is not going to be going that approach. We got to treat the LPA because the ApoB component, there was a nice study from the UK Biobank, doesn't add a lot of risk to LPA. It's all the other stuff most likely that's contributing. So for LPA, we're going to need to get LPA therapies and then treat the ApoB as if it was an LDL type or VLDL type issue. So that's going to hopefully get solved in the next 5 years.
Excellent. Well, we'll have to do this again before the next 5 years because I have enough questions here to write a volume of your next textbook. But I want to thank everyone for joining us this evening, particularly Dr. Tsimikas for taking the time. I think this was an excellent case of residual risk and a missed opportunity to really intervene in this gentleman at a much earlier stage. And again, as I said, we can go on and on. I think LPA is an exploding area between therapeutics and the pathophysiologist Dr. Tsimikas highlighted for us this evening. So this recording will be available at the NLA website on lipid.org under lipid panels. You can join us next month for our next lipid panel, which is always the last Tuesday of the month. And again, thank you, Dr. Vartak, for the case and presenting it, and Sam really taking the time and, going on and on. So appreciate that. And Dr. Meyerson for co-hosting the lipid panel with me. So everyone have a great night, and thank you all for joining us.
Thanks, everybody. Thank you for the invitation.
Thank you.